We are excited to be here together at the 12th annual UNC Water and Health Conference, coming to you from all over the world. I am Lindsay Denny, and I am the moderator for this event. I come with a name tag here, and I am the health advisor for Global Water 2020. So I'm really excited to talk to you today about wash and healthcare facilities, looking at wash and healthcare facilities in the time of COVID and where we go from here. So a few housekeeping notes. First off, well, actually, sorry, if we could go back a slide here, I'd like to recognize all the co-hosts for this event. We are hosting this event with DevWorks International, Engineers Without Borders USA, WHO and UNICEF, as well as the Joint Monitoring Program, UNC, World Bank, and Global Water 2020. And we're all so excited to have you here today. And let's get to the show. So next slide, please. So we have a really exciting agenda for you, broken down into a couple pieces. This is an hour and 45-minute session, but it's going to be really excited and jam-packed. So we'll start with some introduction and context coming from WHO and the JMP. We then have a panel discussion with a number of practitioners talking about their experiences with COVID-19 and wash and healthcare facilities. And again, looking forward as we think about where we go into 2021. We then have an opportunity for audience question and answer with the panel, and we'll talk about how that will function. And then we really hope you'll stick with us to join a discussion around the research agenda proposal, as well as having a chance to talk about what should be included in that. So we will have breakout group discussions starting at 2:30 Eastern, and then we will have a few minutes to wrap up and talk about next steps. Next slide, please. So a couple notes about the logistics here. As you noticed, you're here in Zoom. This is the first day of the conference, so I know it'll be a bit new to everyone getting used to this system. What I recommend is that you keep the Pathable page open. That's the link to which you got to this Zoom meeting. Keep that open. As you'll see, there's a couple of features on there that you'll use throughout this session. The first is a chat function. So we've disabled the chat function on Zoom and are asking people to enter their questions or comments in the Pathable page. Again, this is the main page of how you got to this session. You can enter your questions throughout the session as well as specifically during the Q&A. We also have several polls, which we'll talk about in just a moment, to answer throughout the session. Again, keep this interactive. And then lastly, we will have breakout sessions, and you can join the breakout sessions through that main link. Again, we will explain that as we go along. So to start us off, we're going to start with the first poll. So if you could go to your main Pathable page, to the polls tab, the question we're asking here is, how is your organization tackling wash and healthcare facilities? So whether you're an advocate, a researcher, an implementer, this is a multiple choice question, and you can choose multiple responses. So if you could just take a moment here to go to that page and respond, it'd be helpful to understand who is in the room with us. I see we have 94 participants, so I'm sure it's quite a diverse group. I wish I could see all of your faces in the auditorium at Chapel Hill right now. So while you're having a chance to answer that, I don't know if we're actually getting live responses to that. I will take a look back in a moment. So we're going to have an introduction here on the state of wash and healthcare facilities, hearing from WHO, Dr. Maggie Montgomery, and from JMP, Dr. Rick Johnston. But we'd like to take a moment to think about what has happened in the past year. We had the opportunity to be together in 2019 talking about wash and healthcare facilities at UNC, and man, that feels like a long time ago. Between the incredible momentum from partners, commitment makers, from the UN actors, as well as the countries themselves, wash and healthcare facilities has been moving on quickly. We are accelerating progress. It's really exciting to see in all different arenas, whether it's research or implementation. And additionally, of course, this year with COVID-19 has highlighted the incredible role that WASH plays in ensuring safe, quality provision of healthcare. So if we are not going to show up the polls, perhaps I will turn to Rick Johnston and Maggie Montgomery for their presentation.
Okay. Hello, everyone. Hello, Lindsay. Thanks. Can you see the slides that I've got up?
We can see them. Yep.
Okay, perfect. So I'm Rick Johnston from WHO, and I co-lead the Joint Monitoring Program for Water Supply, Sanitation, and Hygiene. It's a joint program with UNICEF, between WHO and UNICEF. So I'll present on behalf of both organizations today. And my counterpart, Tom Slaymaker, is also on the call and may jump in for conversations. So the JMP produces progress updates on households, schools, and healthcare facilities every 2 years. And in 2018, we published core questions and indicators for monitoring WASH and healthcare facilities. And that established the basis for the baseline report, which followed in 2019. And that JMP report was accompanied by another WHO UNICEF report, you can see on the right here, the one with the purple square, which describes the practical steps that countries can take and are taking to improve WASH in healthcare facilities. And of course, 2019 also saw the World Health Assembly resolution on WASH in healthcare facilities and commitments from countries to monitor and improve the situation of WASH in healthcare facilities. It also called on WHO to continue producing global progress reports with UNICEF and to report back to the World Health Assemblies in 2021 and 2023. So earlier this year, the JMP team updated the WASH in healthcare facilities database at the same time as the WASH in schools database, which we published in August, and will be presented tomorrow at 2 p.m. Chapel Hill time. Shameless plug, sorry. But the JMP data will be presented as a chapter in a consolidated report on WASH in healthcare facilities, which will come out in December this year. And my colleague Maggie will talk more about that next. So in that 2019 baseline report, these core questions and indicators were introduced along with these ladders, these service ladders, which served as the basis for both the 2019 baseline report and the 2020 update. So besides water, sanitation, and hygiene, we also have waste management and environmental cleaning, which are particular to the healthcare setting and environment. And for each of those services, there's a basic service at the top that's defined, and that's what the JMP tracks progress towards. But there are also definitions of limited services and no services, so you can distinguish between healthcare facilities that have something but not quite meeting all the requirements of the basic service. That's what we call a limited service, and those healthcare facilities that really don't have anything at all. Okay, I want to talk about data coverage really quickly before I get to some of the actual coverage figures. With only 1 year between the two reports, we don't expect the numbers to change very much. And indeed, any changes there are probably more changes in data coverage, getting additional data from new countries, than actual changes in conditions in healthcare facilities. So the JMP only makes global or regional estimates when there are actual data on hand from healthcare facilities in countries representing at least 30% of the population. And this chart shows the increase in data availability between the 2019 and 2020 reports, and there were modest improvements. For example, we went from having 38 countries with basic water estimates up to 52. So that's a lot of new country estimates, but most of those new countries were small, so the population coverage only went up from 35% to 37%. Similarly, for basic sanitation, we increased from 18 to 27 countries. That's a big change, but are still only at 12% of the global population coverage, so we can't produce a global statistic. If we look at the LDCs, click, the least developed countries, we can see that we have much better data coverage. There are 47 LDCs, and for hand hygiene at points of care, as well as healthcare waste management, we have data from countries that represent 70, 80% of the total LDC population. So we have a lot more confidence in those statistics. And healthcare facilities and LDCs tend to face more problems and service gaps. So in this report, we'll be focusing especially on the situation in LDCs. And you can see that we have enough data, more than 30%, to make estimates for basic water, basic sanitation, and basic healthcare waste management, as well as for hand hygiene at points of care, almost there for basic hygiene services, but still a long way to go for environmental cleaning. So that's the data coverage story. What about the actual service coverage where we have data? let's look at those LDCs where data coverage is relatively high. As expected, we see a pretty similar report for these indicators, similar picture from the 2019 and 2020 reports. One important difference to note is that the 2019 report produced statistics up to the year 2016, whereas the new report will have statistics up through 2019. But it's clear that the situation in LDCs is not good. Half of healthcare facilities in LDCs lack basic water. Almost 2/3 lack basic sanitation. Only 1/4 lack hand hygiene at points of care, but you can see from the map on this page that there are still 12 countries globally where at least half of healthcare facilities had no hand hygiene facilities at points of care in 2019. Maybe surprisingly, China is one of those countries, with almost 2 out of 3 healthcare facilities lacking hand hygiene at points of care. And China isn't an LDC. So coming back to LDCs, we see that 70% lack basic healthcare waste management, and there still aren't enough data to give an idea about environmental cleaning, but there were 4 LDCs with data on basic environmental cleaning, which ranged from only 5% in Niger to 43% in Bhutan. So that's a quick teaser for the new Washington healthcare facilities data. You can read more about them when the December report comes out, but you can already explore them online at our website, washdata.org. And with that, let me pass over to my colleague, Maggie Montgomery, who will talk more about the broader work on Washington healthcare facilities, including the new report being produced later this year.
Great, thank you, Rick, and thank you, Lindsay. So I'll just hop right in. The next slide, please. So my name is Maggie from the WASH team at WHO, and just wanted to highlight some of the broader issues around WASH and healthcare facilities and some of the findings around what countries are actually doing to address this issue. First of all, we know WASH is fundamental to quality care, and I know many of you have seen this image before and witnessed it, and I think it's important to reiterate that this is completely unacceptable. I also wanted to highlight that we now know more people are dying from unsafe care than lack of care. And when you think about that, it's startling. It's better to stay at home than to go to the healthcare facilities in a lot of countries. And we know that WASH in particular plays a fundamental role in making sure that care is provided in a safe way and that we can prevent not only infections of patients and their families as well as health workers, but we can provide an environment that allows for much better healing and dignity and respect. So next slide, please. So many of you know about the World Health Assembly resolution, and many of you have been with us on this journey to help make sure countries have the support and the tools they need to implement those elements of the resolution. Just wanted to highlight that the 8 practical steps, which WHO and UNICEF published alongside the initial JMP baseline data, were a distillation of what works in over 30 countries. And these starting with conducting a situational analysis and assessment all the way to engaging communities and conducting research. And I really look forward to the research discussion later in today's session, are really fundamental to systematically and sustainably improving WASH services. We now know that over 60 countries are making progress in implementing these steps. And in the next slide, I'll show you specifically what that progress looks like. So it's really encouraging to see that there is progress. We have over 100 commitments, and many of the organizations on this call today have made commitments, and we really thank you for those commitments, and thank you for providing updates on how the implementation is progressing. At the regional level, we're seeing a lot of development around not only bringing together the political and the national leadership, but also providing the technical support. And so this is happening in over half the world's regions. And specifically on WASH Fit, which is adapted from the water safety plans and is a tool to incrementally make changes that WHO and UNICEF have published, we see that this is happening in over 30 countries. So lots of signs of progress. Next slide. And if you could just flip to the next advance, because there's a bit of animation here. So on the country tracker, so this is looking at 5 of the 8 practical steps. We now have data from 50 countries. Not all those countries are in this tracker now. We see that most of the progress is on the initial situational analysis, developing roadmaps and standards. So over 75% of countries have done this to some extent. Now, green means they're completed. You see many are in orange. So orange is that they've started, but they still need to implement, or they still need to disseminate, or they still need to cost and fund the strategies. However, if we go further along the tracker and we start looking at investments in infrastructure and really making those infrastructure changes, as well as the streamlining and the integration into health, and we're measuring that through integration into regular health systems monitoring, we see that far fewer countries have made progress on this. So there is obviously still a lot more that needs to be done, and a lot more that needs to be done in terms of the institutionalization and the national support and investment in this work. Next slide. Just wanted to highlight a few of the country examples of work that we're really inspired by, and that we're hoping that other countries can look to their neighbors and look to countries in other regions to understand how some of these changes can be made. So for example, in Cambodia, they've been able to integrate WASH into their national health equity and quality program. And not only is WASH regularly monitored as part of this quality program, it's actually incentivized. So facilities get payments for meeting certain WASH standards, which helps them achieve their broader quality goals. In Ghana, they've been able to integrate the community scorecard effort, where communities are not only rating WASH services, but also coming up with solutions to how some of these services can be improved as part of their regular health systems monitoring. So it's a really interesting approach to pull in qualitative data with their quantitative data, which then can be looked at much more holistically in terms of how facilities are doing to meet national standards and regulations. Next slide. In Philippines and in many other countries, we see that there's a big push to institute climate resilient WASH. And this is part of broader efforts to make sure facilities and their services are climate resilient around energy, around waste, around water and sanitation. So there's now national standards that are being implemented through a WASH fit process. In Colombia and throughout the Americas, we have a number of first ladies who have really made an impassioned plea for WASH and healthcare facilities, and are taking this on as one of their core causes to really engage national leaders, but also a much broader national advocacy movement. And lastly, in Bhutan, just wanted to highlight some of the innovative local technology work they've done, where they've developed a joint hand washing and drinking water treatment station. And we know hand washing and hand hygiene more broadly is particularly important for COVID, which is being rolled out now in hospitals throughout the country. Next slide. So just before I conclude, I wanted to just mention that the Hand Hygiene for All initiative, which is really about amplifying and about massively scaling up not only access to hand hygiene, but also hand hygiene behavior, provides a really opportunity for the healthcare facilities effort because of that particular focus and importance on hand hygiene, and healthcare facilities being obviously one of the most important settings. So that initiative is obviously prioritizing the underserved, but also looking at how we can invest in sustainable infrastructure, not only as part of immediate national COVID plans, but as part of longer sustainable development planning. And certainly the focus on the country roadmaps, again, on the hand hygiene gives an opportunity to bring together and reemphasize the particular setting of the healthcare facilities. Next slide. So just wanted to end that if you haven't gone to our knowledge portal, I've listed the portal here. You can load things directly. So this site is really meant to be a site where all of the actors engaged in these efforts can share, they can learn. There's also a newsletter that we encourage you to subscribe to. And there's also a commitments page where you can make your commitment. We've listed all the commitments that are there so far, and we'll be tracking implementation of these and providing those updates throughout the site. And as Rick mentioned, there is a global report where we're going into a lot more detail on the country tracker, the country examples, the much broader efforts on engagement with health, as well as the analysis of the JMP data, which will be coming out the 14th of December. So please stay tuned for that. There will be a global think tank where you're all invited to participate. And we really hope that you can use the report and the new data that's coming out to further accelerate the work that you're already doing on healthcare facilities. So thank you.
Thank you so much, Maggie and Rick. Really exciting to see all the things that WHO and UNICEF and the JMP are spearheading and certainly leading the charge here. And I'll reiterate Rick's plug for tomorrow at 2 p.m. to hear more about the JMP data. And I hope you all are looking forward to the report launch. I know I am. So we have a message from the field here from Ppe Disposal. He's the chief of party for the USAID Nepal Swachhata work that DevWorks is leading, which is a wash and healthcare facilities program, I believe in 80 healthcare facilities in Nepal. So if we could play that.
Especially, I would like to introduce myself. I'm Ppe Disposal. I'm working with Swachhata, this DevWorks international supported program in Nepal as a chief of party. Especially, I'm really happy to join and join this conference. It's a very international conference. This is a good opportunity for me to present what are the activities done by the DevWorks International in Nepal. Especially this project is supported by USAID, and in Nepali name is Swachhata. Swachhata is a hygiene project. It is a pleasure to share some of our learning and experiences in this prestigious, is a high-level conference internationally organized for water, sanitation, and hygiene. The USAID Nepal Swachhata project works on wash in health facilities. Swachhata in healthcare facilities in the 5 districts in the Western Development Region of Nepal. By the end of this project, at least 80 healthcare facilities will have new or improved small-scale safe water and maintenance systems and functional sanitation systems that are sensitive to people with special needs, such as pregnant women and people with disability, and children who are those looking for the services. In addition, at least 60 healthcare facilities will have new or renovated solar power supplies with affordable maintenance system in place. During this COVID-19, we have been able to continue our work on wash in healthcare facilities. We have been able to continue construction works, on-site coaching and supervision of infection prevention, and provided this behavioral change communication activities and some health facilities and communities meetings with precautions in places. Swachhata project has distributed infection prevention equipment, training in power, and capacitated all of these peoples engaged in the program activities, and all the activities has been institutionalized at the healthcare facilities, and the development infection prevention readiness plans has been in place in most of the health facilities where Swachhata project is contributing. The primary needs that existed prior to the COVID-19 pandemic are the same as the current needs for wash in healthcare facilities. But These needs have been highlighted more work in the provinces has highlighted the opportunity for greater coordination among the actors. All those actors are in the single chain is to contribute for the project need and real thrust of the community people. For example, the provincial health service directors in Karnali province formed a health and nutrition cluster to harmonize efforts among the provincial government, the UN, non-governmental organizations, United Nations partners, development partners, INGOs, and civil society organizations who are those used available resources to respond to the COVID-19 emergency in Nepal throughout the country. One of the biggest challenges for work in healthcare facilities has been the stopping that has come from the government of Nepal's lockdowns. Many planned construction activities in the healthcare facilities were delayed due to this COVID-19, although they were not cancelled and are ongoing now in many areas at the country level. At the same time, as noted, the primary challenges in healthcare facilities remain the same as they were pre-COVID situation. Swachhata's project's early assessment of healthcare facilities in 2016, even 17, reveals several issues that are still pertinent today. The assessment looked at 107 health facilities in 3 districts, Rukum, Salam, and Rolpa. Dolpa in province number 6, the Karnali province. Issues related to infection prevention, readiness, water supply, sanitation, and hygiene were identified a key, really very important factor for the peoples who are those are in the rural and in the remote areas who are looking for the services from the government as well as the development partners, INGOs at their household level. In Nepal, the gap in the worst situation in healthcare facilities has only been accepted by COVID-19. Work has been able to continue, but with adjustment to ensure the health and safety of project staff and contractors. Looking forward, we need to primarily to focus on supporting the government to fulfill the resources gap. As we find, the health sector is receiving a maximum of 4.5% of the total national amount budget, but this year the government increased the health budget by 24.16% from 68.78 billion 2019 to 2090 to 90.69 billion in 2020-2021 to address the COVID-19 pandemic. Even then, the budget allocation is far below the WHO standards, so that we always be looking for to supporting and increasing required budgets to fulfill the immediate need of the health facilities and the people of the rural areas. Facilitating capacity development of existing human resources. Although Nepal has increased the capacity to produce necessary human resources for health, the present status meets less than 40% of the WHO requirement. Secondly, there is an acute shortage of health manpower, doctors, nurses, paramedics, A&M specialists in rural areas. Playing an active role in infrastructure development where the healthcare facility is operating in a hard building. The building facilities are poorly managed with lack of necessary manpower, beds, equipment, and medicine. Supporting establishing functional coordinated action on the governance system into 3 types of government, rural, urban municipalities, provincial government, and federal government in health system. Fulfilling the gap in rural and urban disparity in terms of basic health services into the people in need. The work we do in WAS supports all of these areas and is necessary to improve the status of healthcare facilities in Nepal.
Thank you so much, Ppe. Great to hear of the situation on the ground and what it is like in Nepal, at least. Hearing some of the challenges being faced and where we go from here, particularly as we think about the impact on COVID. So we are going to have a panel discussion. I want to first bring back around the poll results. So those of you who answered how your organization is tackling WASH in healthcare facilities, it seems a pretty even divide across the types of activities here. 20% of you all are working on training and education, 17% looking at infrastructure and service provision, 15% on behavior change and management. So a nice cross spread. Some of you, 7% of you doing something else. I'd love to know what that something else is. Please feel free to put it in the chat box. So now I'd like to move on to our panel discussion. So if my 5 panelists could get themselves prepared, we will hear again from Ppe Disposal from USAID Nepal's team with DevWorks, Waleska Crow from EWB Engineers Without Borders USA, the Guatemala Deputy Director, Maggie Montgomery, who we just heard from, Technical Officer at WHO, Claire Chase, who's a Senior Economist with the World Bank team focused on water, and then Nikki Benke, who is a Research Associate at the Water Institute at UNC. So welcome to our panelists. We're excited to have you here. And I'll start with our first question. So thinking about COVID-19, I wonder, does COVID-19 change our approach to WASH in healthcare facilities? And if so, how do you see that approach change? And this question is for Maggie.
Thank you, Lindsay. It doesn't change the approach. And fortunately, the evidence continues to suggest that when we put in good WASH measures, we can make sure, for example, that it doesn't survive in wastewater. We can make sure if we do proper hand hygiene, we can remove it from our hands. But it does obviously emphasize the urgency for action. And I think on the positive side, we've seen many countries that have done rapid assessments of healthcare facilities in the hardest hit areas and found that there's huge WASH deficiencies, as we've just heard from our colleague in Nepal. And those facilities have been prioritized in terms of some rapid improvements. But I think that brings me to the second point, is that it's not just about putting in facilities and not thinking about how they're going to be maintained or how they're going to be properly used. So I think it's really important that while the immediacy is on COVID, that we think about the importance of functional and reliable services, because ultimately that is what we're aiming for, not some temporary services or even temporary hygiene behaviors. And just the third thing I wanted to emphasize is all along this effort hasn't been about WASH, right? It's been about WASH to achieve health aims, better quality of care, reduce maternal and newborn mortality. And again, this COVID pandemic is really important that WASH is streamlined within COVID national plans, within funding, within monitoring. And if it's seen as something separate, it won't get the attention and it won't get the amount of funding and resources that is needed. Thanks.
Thanks, Maggie. And I think that's something that we've all been grappling with over the last 6 months is what does it mean for us with COVID? And I think you answered that so succinctly in that it doesn't change it, but we need to see how we can do more, better, and stronger, essentially, to make sure that we're really building up the system. So for our next question, we actually have 2 respondents here. Going to go back to Ppe Disposal and then also Waleska Crow from Engineers Without Borders. And as 2 key implementers working on WASH in healthcare facilities, I wonder, what are the emerging challenges and opportunities you found, particularly in the context of COVID-19? And I wonder if we'll start, did you want to start, Nikki, with Ppe?
Yep, sure.
Apologies, it is really late in Nepal right now, so he's provided us a summary.
To the emerging challenges and opportunity which we are just facing in Nepal. I would like to just share about the COVID-19 and its pandemic. I'm sure it will be definitely change health service delivery, and healthcare system has faced significant challenges to restoring services not only in hospital, but also in social care, primary care, mental health, and community-based services. Due to COVID-19, communication channels with communities and patients have been modified and in many occasions organized discussion online and virtually. I believe that virtual discussion might not effective on patients and public engagement because of it will be difficult to collaborate and build relationship and trust without visual representation. It will be difficult for community leaders and public to discuss, debate key issues in real time, difficult for community leaders and patient representatives to garner public support. Disbanding the established patient groups risk trust and goodwill working jointly with the community's priorities, needs, and strengths. This can be achieved through meaningful local participation and engagement, with a particular focus on those who experience ill health, disability, and inequality, and supporting people to improve their own health and promotional health care services under local health system need safeguards the role of volunteer and community organization. At the same time, the water sanitation hygiene needs in healthcare facilities have not changed so much. They need access to safe water, sanitation, hygiene infrastructure, as well as adequate infection prevention measures and primary protective equipments. From the Swachhata project perspective, our work continues only the delivery model. However, we compelled to change it to ensuring staff safety and to help prevent the spread of COVID-19. For example, the number of people in a group on site is smaller and all staff and contractors wear appropriate protective prevention equipment. The breakdown of the basic health services because of COVID-19 pandemic is emerging new health threat in Nepal. The available statistics shows that a total of 812 people on 22nd October 2020 died due to COVID-19. 600 died of suicide. More than 300 women died of pregnancy-related complication within April and May 2020. In addition, thousands of children have delayed routine immunization and other essential health services. There are several challenges identified in healthcare facilities in Nepal, which includes not limited to provision of water, sanitation, hygiene facilities as one of the priority and an internal part of quality services in healthcare facilities. Provision of standardized water, sanitation, hygiene services to enable the health workers and patients to practice hygiene behavior and prevent infection. Inclusion of indicators on water, sanitation, hygiene facilities in healthcare facilities in the health management information system. Putting in place sustainable mechanism for operation and maintenance of water, sanitation, hygiene facilities in healthcare facilities. Awareness raising among community and healthcare facilities members on need and effective use of water, sanitation, hygiene facilities to avoid potential infection, and infection prevention measures are lacking, including the availability of PPE in many healthcare facilities. The Swachhata project is working on addressing all of these pertinent issues and challenges that supporting to the community as well as the healthcare facilities. However, still there are many opportunities to address in achieving the bigger health gain through suppression of disease transmission by strengthening institutional structure, education, and ensuring water, sanitation, and hygiene facilities in healthcare facilities. The following points might be considered as opportunities. The number one, strengthening health infrastructure information management system to generate information on water, sanitation, hygiene as critical priorities of each facility. Ensuring water, sanitation, hygiene as a progress milestone of every healthcare facility. Dedicated funds to ensure operation and maintenance of the WAS facilities. Ensuring provision of water, sanitation, hygiene facilities in all healthcare facilities. Engagement of local water, sanitation, hygiene authorities and local coordination committee for technical support, implementation implementation and monitoring and utilization of water sanitation and hygiene services, and ensuring hygiene behavior of the healthcare facilities. Personnel would lead to regular counseling and further ensuring hygiene behavior for infection prevention among vulnerable children and families. Uh, Thank you very much for the opportunity to speak to you today. I really appreciate your providing me a time. My colleagues will help or support answering any follow-up questions you might have, and I'm happy to connect as well. Thank you so much for your kind attention and hearing what I'm sharing on behalf of this project, a Swachhata project supported by USAID and managed by DevWorks International in Nepal. Thank you so much.
Thank you so much, Ppe, for that. And as you noted, members of the DevWorks team are here as we get to the Q&A portion. So feel free to include any questions you have in the chat box for them. But I really appreciate, it's a stark view of what's happening on the ground. But that list at the end there of opportunities makes me think back to the 8 practical steps and what we are trying to achieve broadly to ensure wash and healthcare facilities for everyone. So I turn to Waleska Crow from Engineers Without Borders USA. Waleska, for the same question for you, what emerging challenges and opportunities have you identified in your work, particularly as it relates to COVID-19?
Thank you so much. Well, Abby said it very well, but I will focus on some of the things that I have seen that can be highlighted. Of course, in Guatemala, we have seen that the very basic elements for the centers to be called health care facilities are lacking. For example, some are lacking water or reliable source of water and do not have access to a way to storage. And they are also lacking sterilizing equipment and all the issues that we know that are common in the world. And as we solve those problems, I see that it is very important to take into account that we have the opportunity that COVID has highlighted the importance of working in healthcare facilities. And it is important to bring everybody together to start collaborating, non-governmental organizations as well as governmental organizations. This is a great opportunity to rethink how we can work together so that we can invest the resources better and therefore have better outcomes out of our interventions rather than looking back in 10 or 15 years and saying, oh, different organizations did the same work or we didn't really make a difference. I think it's very important. And it is also important to think about what the standards are for the design of a basic healthcare facility. Are we being inclusive? Are we including people who have special needs? Are we including hygiene for menstruation? Is it important to think also to think about nursing mothers? And so rethink about what a good design for a healthcare facility means. I think that those are the great opportunities. The challenges are that everybody can come up with the same agenda, that we all have we all agree that we have to have these interventions, and then collaborating and coordinating together with the government, with the communities, with the healthcare system workers. I think that is a challenge, but I don't think it's impossible to bring everybody together. That's all I have to say.
Thank you, Waleska, and I appreciate your focus on the opportunities over the barriers here. I think, as you've pointed out, there is a moment here to rethink and reimagine. I know this is part of the Hand Hygiene for All campaign, for example. How do we reimagine the future around wash and healthcare facilities and ensuring we have access for all sustainably, not just until 2030, but beyond. So thank you for that. My next question actually goes back to Maggie and to Waleska here. So we know that we have this great need. We know we have opportunities. What emerging technologies or tools are available that we could use to address wash and healthcare facilities, either now in COVID or beyond? And Maggie, maybe we'll start with you.
Sure. Thank you, Lindsay. Yeah, I just wanted to highlight 3 technologies, and I'm glad you mentioned tools, because I think we, as engineers, we jump towards technologies, but we know they're only as good as how well they're maintained and used. But first is on the waste side. So we're just starting to pull together the data and a report on the implications of waste in COVID, but we know they're quite monumental, not only with the PPE, but with the impending global vaccine effort for COVID. But we also are seeing that there are a number of new technologies, both on the burn side, even though we don't necessarily recommend burning as the endpoint, but we do see at the local level, there's innovation around how incinerators are being made to burn waste at higher temperatures. So there's less pollution and particulates in the air, but also that they can be more easily maintained. But also on the autoclave side, which is certainly what WHO and the broader environmental community recommends, that we're starting to see more and more low-cost autoclaves that can be used to effectively treat the waste to make it non-infectious. On the hand hygiene and drinking water, there's a number of new technologies that are coming out around both hand hygiene facilities, as well as facilities at the same time can be used to treat drinking water and make that available, because we know they're both important needs. And the Hand Hygiene for All initiative is working on some of these. And I highlighted one example in the talk from Bhutan. And then the last one is just on locally made alcohol-based hand rub. We know that this is obviously the convenient solution and is certainly preferred when the hands are not visibly soiled. And many countries now are starting to produce this locally and distribute from Africa throughout Asia, and that's really exciting. And maybe just backing up one on the tool, the wash fit isn't the only tool, and certainly we encourage countries to use it as a starting point, but to rip it apart and make it their own. But I think whatever tool is being used, the obvious importance of looking at incremental improvements, of monitoring those improvements over time, and trying to do the improvements in such a way that they're based on risk is really important. So it's really exciting to see that before any technology is adopted, that there's an approach that's being thought about the whole sustainable system over time, about what can work and what the facility and the community can actually maintain themselves. Thanks.
Thanks, Maggie. And I think you said a buzzword there that I think when we talk about tools and technologies, there's also this idea of approaches. And I realize an approach is a very vague term, but I think thinking about the whole system and how do we integrate all of these pieces of technologies and tools into a wider system or approach that might be applicable in the post-COVID-19 era, where Washington healthcare facilities has a greater prioritization. So I put that out there as more questions to you all. Feel free to use the chat box. What have you seen as technologies, approaches, or tools that are working, emerging ones that you've experienced or would like to test out? But then I turn to Aleska. Engineers Without Borders, what tools or technologies or approaches have you all seen taking shape now?
Thank you. Yes, so we have been seeing, and we're forced to use mobile data collection during COVID when we first saw that it started. So we needed to gather information. And there is actually a tool that was worked between EWB USA and Food for the Hungry. And it is based on the WHO and UNICEF wash fit tool, and also some of the technical briefs that they take out for COVID response. So it adapted those indicators, and we were collecting the data through mobile with Kobo Toolbox, and it is also being displayed by Power BI. And that is a way where people can have access to the information. And it's not only Engineers Without Borders in Guatemala who are using this tool. We are also like Water for People and other organizations are using it. And we all have access to the same data. And I believe that is very important because, as I was saying previously, it is necessary and very recommendable that all of the entities that are intervening in healthcare facilities have the same information and make sure that everything is coordinated. So that is one. And the other one is that I have seen that virtual conference call platforms have been arising. We haven't stopped during the pandemic our work here in Guatemala, and we have been able to be creative to talk with other people like healthcare facility directors, mayors. So we are now using Zoom or Google Hangouts, you know, having meetings with people that we were thinking we are not going to be able to meet. How are we going to continue to work? But it's now being possible for us to talk with even community leaders through these virtual platforms.
Thanks so much, Waleska. And interesting to bring up something like Zoom as we are all sitting here on Zoom chatting. I definitely agree that innovation, we've been forced to innovate in the face of COVID-19 in some ways that might be beneficial beyond. So I have one final question before we open it to question and answer session. And again, I encourage you to use the chat box in the Pathable platform if you have questions for our distinguished panel here. But a question for Claire and Nikki around costing. And what is the cost of Washington healthcare facilities? This is something that has come up in every meeting we've been having for the last 5 years. And I think we are always grappling with it. And I'd be curious to understand, what do we know about the costs and benefits to date? Have we made progress on this? And where do we go from here in understanding this? Because certainly all of this implementation, we need to get someone to pay for it at the end of the day. So Claire, I'll let you answer first, and then Nikki, if you want to follow up.
Thank you, Lindsay. And it's great to be here and this really engaging discussion. So, I mean, whenever the topic of cost benefit comes up, I'm always reminded of the work that Guy Hutton did when he was with the Water and Sanitation Program at the World Bank on the economics of sanitation. And this was really the first time that we were able to put systematic evidence in front of ministers of finance, in front of country governments, demonstrating that lack of investment in sanitation and basic sanitation was costing governments tens of billions of dollars a year. So that obviously was a huge wake-up call for many countries and really turned the tide in how countries were willing to invest in sanitation. And at the World Bank, it also opened up opportunities for our project teams to advocate for inclusion of sanitation as part of country programs. So I think at the global level, it is really critical that we have a cost-benefit analysis that's able to demonstrate the severity of the situation and really kickstart those discussions in global forums about how much it's going to cost and who's going to pay for that. But I think I want to also push this a bit and ask ourselves, you know, the situation that we're in today is quite a bit different from where we were with sanitation. And the question I have is, how can we, and to what extent can we leapfrog this in-depth exercise and really take advantage of the momentum that's been created by this unfortunate pandemic that we're all facing? While we have the attention of the global community, how can we use this as a window of opportunity to help raise the profile of the needs that are required and use the evidence that we have at our disposal to advocate for those funds? So critically now, I think it's we need to raise the funds. We know the costing that's going to come out in December that Maggie mentioned. We know that's going to show that enormous investment needs are required. And it's also going to come out in a time where budgets are tightening, priorities are shifting. There's going to be a lot of competition for these funds. So I think I want to focus on two messages really when we think about how we can go about raising funds for Washington healthcare facilities. The first is to leverage the opportunities that are out there on what are the priorities. So in the World Bank, when the World Bank announced $6 billion in health-focused financing for COVID response, we used that as an opportunity to advocate that every single one of those projects was including Washington healthcare facilities where it was needed. And so 30 as of today, 35% of the health-focused fast-track financed projects of the World Bank have included WASH in healthcare facilities. We need to do the same for the Universal Healthcare Agenda, for the other global health SDGs, as well as leveraging the emphasis on antimicrobial resistance. These are all priorities that have been elevated now that WASH in healthcare facilities fits right into those. And the second message that I want to emphasize is we need to be taking advantage of stimulus spending. A lot of countries are now putting forward packages to kickstart their economies. WASH, water and sanitation, is a labor-intensive sector. It creates jobs, it leads to economic growth. So we should be, WASH should be one of the priority interventions that countries are putting money towards. And of course, any of those water supply and sanitation interventions, they need to be including WASH in healthcare facilities as part of the package. So all that's to say that we continue to work on the cost-benefit analysis, which in fact is led by UNICEF and WHO. But in the meantime, we need to take advantage of this window of opportunity. So thank you.
Thanks so much, Claire. Nikki, from your perspective on the investment case and cost benefits analysis, how is UNC approaching this?
Yeah, definitely. And I want to say I agree with Claire about kind of seizing this moment and making sure we are using the evidence that we have and taking advantage of what we already know to kind of make evidence-based decisions. So UNC and others have been working with various actors to kind of develop these costing tools for environmental health services in healthcare facilities. And there's really a demand, as we've been saying, for better data to inform budgeting and our understanding of the costs and benefits of these services. So UNC has been working with UNICEF to kind of lay the groundwork for an investment case for WASH in healthcare facilities. So before we really launch into quantifying the costs and benefits, we wanted to determine what data are already available, what's already out there. What do we know? What are the causal links between environmental health conditions and human health outcomes and socioeconomic outcomes? So what we decided to do is take kind of a two-phased approach. And the first phase is to sort of scope out all of the information we already know, identify where we need to do expanded literature reviews, where we need to go and collect field data from the field. So we're conducting a series of systematic of scoping reviews to get a sense of where the evidence is, looking for causal links, health outcomes, and then the costs. And then once we've done those first set, kind of laying the groundwork of the data and the evidence that already exists, we'll launch into phase 2, which will involve expanded literature reviews, some disease burden modeling, and other methods of kind of filling the gaps to ultimately produce a cost benefit model that can be used to make the investment case for improving WASH in healthcare facilities. So it's what our approach has been to kind of first take an inventory of what we already know and what the evidence already says, and then fill in the gaps so that we're not duplicating efforts.
Great, thanks so much, Nikki and Claire. And it's exciting to see the progress on this from a couple of years ago, where cost was the elephant in the room that we wouldn't talk about, to several years later, where we recognized that we need to better understand it, but hadn't gotten our arms around it, to today, where it really looks like there's progress. And hopefully in 2021, we'll start seeing, as Claire talked about, the results from all this, but also how we take advantage of this in a larger discussion around financing both domestic resource mobilization as well as ODA and other forms of financing. I do want to note, in many of you participants on here, I realize these are big topics here, talking about costing and a large investment case. I encourage all of you who are working on implementation to consider how you document the costs of the work that you all are doing. I think it's each one of you all with your programs and budgets, you're starting to see what the operation and maintenance costs are. You're starting to see what the life cycle costs are. What is your capital investment? And that information is so critical to help groups like Nikki and Claire to start compiling this, but also so that we can have a better idea next year when we talk about emerging technologies, we can also start saying, and this is what it'll cost to start doing these programs at X scale. So I put that plug in. Hopefully you all are thinking about that already. So we have a few minutes here to have some question and answer. I already have some questions in the chat box I'm going to pull out and talk about. And on behalf of Ppe Disposal, we have two people from DevWorks, Ashta Thapa and Marjorie Huang. So thank you for joining us on his behalf and speaking about DevWorks's activities. We also, you can point your question towards Maggie, Waleska, Claire, or Nikki, and so exciting to see a strong female panel here. And I would love to hear from you all. So let me start out with a question from Eddie Perez. Eddie, if we were in person, I could picture you in the back of the room, raising your hand, standing up and starting us off here. So Eddie had asked, what progress is being made by the government health sector to have sustainable funding for operation and maintenance of hand washing facilities? And I'd certainly expand that to all wash facilities being constructed as a result of this emergency period. So I open this to anyone who would like to take a stab at it. I know we had a comment in the chat box already, but how are we looking at the funding for sustainable funding for these emergency implementation?
Happy to quickly comment, but I'm sure Claire could offer some additional insights. But I think this is certainly speaks to some of the broader costing and budgeting work that WHO and UNICEF are doing. And in particular from WHO side, we're obviously very interested in the Ministry of Health budgets and how we can get WASH included as part of discretionary funding. And there's some examples, for example, from Ghana, where at the district level, they've been able to add WASH and healthcare facilities as part of that discretionary funding. Another example comes from Timor-Leste, and that was really a hand hygiene focused effort that was looking at improving not only access in healthcare facilities, but behavior. But again, they were able, through a lot of national advocacy and leadership and through data showing how important that it was to have these facilities in healthcare facilities to add those budgets. Now, are those budgets sufficient? No. And, you know, I think Claire made a really good point that we're all going to be scrambling for smaller and smaller pieces of the pie when it comes to government budgets. So I think from WASH, it's also really important to prioritize, you know, what are the critical things that really need to be maintained if resources are scarce.
Claire?
Maybe I can comment on this question. And I think this is actually one of the areas that I would emphasize is really where the research agenda should be focusing, which is on the first is how can we structure the incentives for the capital investments, but also for the operations and maintenance. And then I include in operations and maintenance the compliance with, you know, the hand hygiene, the infection prevention, and those sorts of things. So how can we structure the incentives to get those things moving? And then secondly, what are the financing mechanisms for sustainability? I don't think we have very good evidence, and we don't have a lot of experience that's really looking into those specific implementation science sort of research questions. So one thing that we're looking at the bank is using results-based financing, performance-based approaches. We know that those in many cases do include WASH functionality, but it's so embedded in the quality of care checklist that they're using that, you know, we're not sure to what extent this is really leading to better outcomes because it's not been prioritized. So we really want to look into this more critically and you know, work on some research around how to use these sorts of mechanisms to get the systems, you know, not only just the capital investments, but get the systems actually functioning over time. So I think that's a super exciting area of research. Sorry, I don't have the answers today.
No, but it also points us to the idea of this humanitarian development nexus. We're in a protracted crisis. Much of the initial funding for COVID-19 response was emergency funding, but we know that this issue certainly is systemic, and how do we start transitioning more to a development approach, whether that's domestic resource mobilization or external funding. So, I mean, Eddie, you always ask the tough questions, and I appreciate that. We need to be working with colleagues who are more on the emergency side and thinking about how these funding streams work together. So I have 4 questions here on healthcare waste management. So I hope Waleska, Maggie, DevWorks team, if you can help jump in here. I'm going to try and compile them into a more succinct question or two. But I think it's interesting that that's the technology or question that's coming up. And perhaps in part because it's the hardest thing for WASH practitioners to get their head around is something they're not as familiar with: incineration, burning, what's the best practice? So it looks like a lot of these questions are around technologies that are used for PPE, what would be the best for healthcare waste management, as well as what's recommended for smaller rural sites, as well as alternatives to burners and autoclaves. What kind of innovation is there because of the dangers of incineration? So I just threw you a number of points there. Perhaps the DevWorks team, I think one of these questions was originally pointed to you all in Nepal and innovation. Do you have any thoughts about healthcare waste management from your experiences?
Sure, this is Jeannie. I can talk a little bit about this just for a second. So one of the things that the Swachhata project has been doing is, focusing on the dangers of incineration and initiating a discussion on healthcare waste management. So that's, driven the focus on autoclaving and recycling materials. And I do want to give a shout out to my colleague or former colleague, Antoinette Combe, who's been jumping in on the chat. S&V has been a great partner working with us on this project.
Great. Others on the call, thoughts on how we improve healthcare waste management technologies, innovation, what we do in rural settings, what is the recommendations for PPE disposal? Maggie Montgomery by chance, and then Waleska.
Sure, I'm muted. Unmuted.
You're good.
I'm good. Can you hear me?
Yes.
Yeah, okay, sorry. Yeah, just to quickly jump in here, and I think I said this earlier, most of waste is not infectious, including a lot of the things that facilities are counting as infectious when they're treating COVID patients. So we really emphasize that as much as possible to segregate that waste, and so you have a much smaller volume to begin with. On the PPE side, I mean, there are options to use reusable PPE as long as it can be properly washed and disinfected. And I think that is a really important option if we're thinking about how do we massively reduce the amount of PPE. Now, when I talk about PPE, I'm thinking more about the outer coverings. I know on the masks, that's something different. So we don't necessarily recommend reusing masks in the healthcare facility setting unless there's no other option. And there's all kinds of WHO guidance on all of this, so I'm happy to share the links for those of you that are interested. I think there's an economic question here too, right? Because I think that in many places, municipal waste services don't exist. How do we kind of create a business around this? And certainly Nepal and other countries have really shown that there is a vibrant local recycling economy. And if there's ways that plastics and other parts of the waste in healthcare facilities can be sold, reused, repackaged in a safe way, that can certainly help pay for the rest of the waste chain. And then just the last thing is, as I mentioned earlier, these locally constructed incinerators, and CDC has done a lot of work on this, and we have some guidance on the knowledge portal, are showing promise in terms of options that can be sustained and implemented at a lower cost, but certainly for the larger facilities, you need to think about more advanced technologies, and in some ways there's no getting around it besides having to really think about the upfront investments.
Great, thanks Maggie. Waleska?
Yes, I would like to add illustrate a little bit the situation here in Guatemala. First of all, incineration in the healthcare facilities in the more rural areas are not available, and they are not known by people. And as EWB USA, we are advocating for the use of reusable PPE, as Maggie was highlighting. We have been having a lot of success with these. We've been working with some PPE producers who are producing some reusable stuff. But as Maggie was saying, it's important to think about the costs involved in these technologies if we are going to suggest them, and to be clear, here in Guatemala, we don't know what the technology is going to look like, if it's going to be needed in the smaller places. I think this is a very open opportunity for more research on these type of technologies to come up with something that is going to be sustainable. And I think it's also necessary to think about what's going to be the source of the energy, because when you think about more rural, then you have less things available, but then what you have available is wood. And we are already, as countries, at least in Guatemala, facing problems of deforestation and trying not to use wood as a source of energy. So it's an open question, but I think it is going to be as important as to include the government and the healthcare workers as it is going to be to include the voice of the communities that we are serving to come up with a solution that is going to be good for everyone.
Thanks so much. And I think when we talk about the issue, for example, of reusable PPE, it brings up this question of water access and making sure you have enough water to reuse the PPE. So it really, I think, will require us to think about the system as a whole. And we'll ask talking about the type of energy required for some of these things. So I think taking a step back to think about our design and contextually what's available is going to be really important, certainly for COVID-19, but beyond, how can we, again, reimagine and re-envision what Washington healthcare facilities access will look like. So I'm going to ask one more question to the panel before we move on. And this might be most applicable to our DevWorks team as well as the EWB USA team. So John Oldfield asks, do local and national governments have access to the same data collection tools and the data that's being presumably collected, for example, through the COBO toolkit? Is it easy to share with governments in order to encourage governments to scale up when they're seeing these gaps in WASH service provision?
I can go ahead and answer.
Great, Waleska, thanks.
Yes, it is something that we are being sharing with the government here. It's very easy to access for them, and it's actually feasible for them to also feed the data. Well, the way it's working is different organizations are gathering, are assessing these healthcare facilities in different regions within the country, and it's possible for the government. Now, whether it's going to be something that is going to be used officially by the government, that's something that we as a group here in Guatemala are advocating for. But the government so far has received these very, very well, because, you know, some of the data collection processes are very, you know, in paper. They take time. They're not as fast as these new technologies that are emerging. And in the process of collecting through paper, this also can take time, and sometimes the data gets not well processed. So this more automatic system makes sure that we have the data and that we analyze it well. And so I think at least the experience in Guatemala, just to be concrete on that question, is yes, the government has access to that information. They have shown interest in that. We are still having conversation whether that's going to become something that the government is going to use also.
Thanks, Waleska. Any final words, DevWorks, on your end with data collection and providing that to the government?
Yes, so we're actually, we've adapted the government of Nepal's 14-point readiness score related to infection prevention. So we're actually using a 12-point readiness score because 2 of the points don't apply. And so we are able to feed in our information into the government's system. That is something that, you know, is that we can open up to the government to discuss to do. But yes, we have that information available. So it is possible to feed it into their system.
That's great. And that's, sorry, Jeannie, did you want to add to that?
Yeah, just to say, but at the same time, there's a lot of WASH information that's missing from the government's healthcare management information system. And that's an area that Ppe noted in his remarks as an opportunity for improvement.
Fantastic. And that is part of the 8 practical steps, is getting this monitored and integrated into existing monitoring systems rather than having parallel external systems, which may not be as regularly monitored or implemented. So thank you all for your comments here. I really appreciate, I'm giving a round of applause to the panel here. There's a couple other questions that actually translate us or transition us nicely into our last section here on the research agenda. So I'm just going to read them off because I think we're actually going to answer them through some of this work. One of the questions here from Rebecca was, are there outstanding research questions or knowledge gaps that are limiting our effectiveness in addressing WASH in healthcare facilities? Or are the limitations mostly in the implementation of WASH services? And then Claire Kilpatrick asks a question about what can be learned from hand hygiene in healthcare for more than a decade of intense work and research in that area. Again, pointing that this isn't necessarily a question to be answered right now, but something we need to consider as we move forward. And as hand hygiene is a major focal point of the research agenda, and certainly thinking about where we have gaps in our research to date, I'd like to transition over to Nikki Benke to give us an update on the research agenda, the proposed research agenda, and where we go from here. Nikki?
Thank you, Lindsay. Elizabeth, if you could go to the slide with the figure on it, please. So as Lindsay mentioned, we've had a bit of a delay, partly due to COVID, in producing a research agenda for WASH in healthcare facilities. And last year's event does feel like a really long time ago. But we've been thinking through ways to kind of develop a framework for how we can approach this research agenda. Okay, here it is. Great. So just talking through this quickly, and just keep in mind, this is meant to be a starting point. It's not supposed to be the end all be all of a research agenda for WASH in healthcare facilities, but it should give you a kind of starting point for the breakout group discussions at least. So this framework starts with examining the conditions themselves. So WASH, and then also other components of environmental health, some of the ones we've talked about on the panel, including waste management, energy, and PPE sterilization. And then it moves towards demonstrating salience, meaning that we want to make connections between the conditions and why this actually matters. So that can be connections to human health or to social and economic outcomes. The next component of it, kind of going down one more level, is, okay, now that we know what the causal links are, how do we identify solutions, and at every level? So that goes from individual behavior change to the health system level, to making an enabling environment for these solutions. Then the next step would be demonstrating effective implementation of those solutions, and that includes evaluating software and hardware interventions, sustainability, different tools, and cost-benefit analysis. And all of this kind of moves towards the ultimate goal of policy reform and kind of scaling up effective interventions and mobilizing funding through advocacy. And so different stakeholders in different parts of the WASH and health communities have different strengths and weaknesses and different roles to play in this framework. You might see a place where you think your organization fits in well, and we'd love to hear about that. And like I mentioned, this is not meant to be the kind of end all be all of the research agenda, but it is meant to facilitate discussion and feedback. At some point during or after this side event, we have another polling question, which is about your organization's research priorities for WASH and healthcare facilities. And it would be great if you could navigate back to the Pathable page at some point and fill out that poll question. So please use this figure as a starting point for your breakout room discussions, which I'm about to explain. Elizabeth, could you go to the next slide, please?
And Nikki, while they're explaining that, just also to note that the literature review of existing research, as well as a synthesis of that which was completed this morning, and it's beautiful and ready for you all to review, is in the files folder on the Pathable page. So if you want to take a look at the poll and those documents, I encourage that as background information for the research agenda.
Yes, definitely. Thanks for highlighting that. So we can't automatically send you to breakout rooms. So in a minute, not yet, please. You're going to close out of this session and then go to the bottom of the page, the event page on Pathable, and join your designated breakout room. So please take note of which breakout room you've been assigned to. We've just done it based on last name. And so it should be pretty straightforward. So please take note of that. And there will be a moderator and a rapporteur to kind of help guide the discussion in each breakout room. I'll stay in this main event room if you have any questions, if you get lost virtually. And so that'll be about 20 minutes at 2:55 Eastern Daylight Time. We will return to this main session for some next steps and some concluding thoughts. So please come back at 2:55. Your moderator will tell you when. But yeah, so go ahead and enjoy your discussions, and I will see you in 20 minutes. It seems like there's a few people still in this main event. So if you have questions, please post them in the Pathable chat box. Thanks.
Nikki, can you hear me?
Yeah.
It's weird because I clicked on the room 3.
Mm-hmm.
But do I need to do something else? Because like I'm here, but I'm also still with you. But other people obviously figured it out.
You have to actually close. You have to close the Zoom window for this meeting completely, and then go open a new one. You can only have one Zoom window open at a time.
I'm
okay, I was having the same problem. Hey, but Nikki, while you're on, this is Eddie Perez.
That we're having robust collaboration and participation. And then finally, only looking ahead as far as middle of 2021 right now, but May 2021 is the World Health Assembly. Hopefully, fingers crossed, it will be taking place as usual. And thinking about what updates will be provided to the World Health Assembly on the country tracker and progress towards the resolution. So those are the primary updates I have. I'm really excited and glad to be with you here today. So thank you to our panelists, to our breakout group moderators, to our rapporteurs, and our co-hosting organizations. It's exciting to be with you on the first day of the UNC conference, and as we continue to push forward with Washington healthcare facilities. So please stay tuned, and hopefully we will have an opportunity to have more group discussions in the future. Thank you all, and enjoy the conference.